most commonly performed procedure for mandibular advancement and can also be utilized for mandibular setback. Let's see how the procedure is done. Incision begins at the anterior aspect of the ramus and runs down through the lateral crest of the oblique ridge. The cut is completed through the periosteum to the bone. Periosteal reflection starts laterally over the body of the mandible, extending to the inferior border and continues over the anterior aspect of the ramus. Then the vertical cut is placed at the horizontal ramus between the first and the second molars and is extended downwards to the inferior border. Is identified. The cut starts above the lingula, parallel to the occlusal plane, and is continued inferiorly through the lateral cortical bone at a 90-degree angle and ends between the first and the second molars. Then we place a channel retractor that fits under the inferior border of the mandible. The osteotomy line between the cut at the medial ascending ramus and the vertical cut is connected. Lingual split is placed using a micromotor. With a 6 mm spatula osteotome, complete the osteotomy beginning at the medial cut of the inner cortex of the ascending ramus to initiate the splitting of the buccal cortex from the lingual cortex. All the contents of the inferior alveolar canal should be separated from their buccal attachments, and the nerve and the vessels should be allowed to fall medially. The split has been completed by slightly pulling the distal tooth-bearing portion of the mandible forward. After osteotomy, a prefabricated interocclusal acrylic wafer splint is placed. We achieve maxillomandibular fixation with 3 ligature wires. The proximal segment is gently moved into the fossa with the use of a ramus pusher, a wire director, or a periosteal elevator. We then fix the 2 bony fragments together. Bicortical position or lag screws or plates with monocortical screws as well as resorbable screws are used to stabilize the segment. After the segments have been stabilized, the skin incision is closed with horizontal mattress suture technique with a 4-0 non-resorbable suture. The suture is removed 10 to 12 days after the completion of the surgery.